had was a single course of azithromycin, subgingival cleaning, and 6 months of maintenance, 6 monthly maintenance. He does eventually lose this upper 7, but let's just go through the series now. So this is the original February 2010, so 18 months later. Is that 18 months? Yeah. About 18 months later, the bone's looking heaps better around there. As I said, he has lost the 7, but things are looking heaps better. July 2011, he's almost not a periodontal problem anymore. So, yeah, that is very impressive. We don't see that in every case, but we see it enough times to make us think there's something going on here that we've never seen before periodontally. And, we've been in the game for a fair few years. Another area where azithro is very useful, and that's in cases that are not responding that well to periodontal therapy. So traditional periodontal therapy, they've had all the flaps and all that sort of stuff. They respond especially well to a course of azithromycin. So this is a person with furcation involvement around the lower molars here. And that's really the best I could get this guy. And again, you'll say, oh, that's because you don't clean him up properly and he doesn't clean his teeth. Well, maybe, maybe not. Maybe he just has this high susceptibility to periodontal problems. Now, this is what he looked like after azithromycin and periodontal maintenance, but no surgery. You can see he's still got plaque around his teeth, but the tissues look heaps better, and this is after 18 months. So they get better and better and better. It's not like it all sort of stops and falls in a heap. For some reason, they keep getting better after that single dose. And looking at the radiographs, that was his original radiographs, and that's what he looked like 7 months later. So that's, furcation defects are the bane of periodontists' lives. For some reason, it does very well in furcation defects. The other area it works pretty amazingly well is related to drug-related gingival overgrowth. Coming back to our friend here, the New England Journal of Medicine, but going back to 1995, this was the first report of the ability of azithromycin to control the overgrowth of gingival tissues related to cyclosporin treatment. And that's been buried in the mists of time, and generally periodontists don't know about that property of azithromycin. This is one case that I treated with azithromycin. He was taking nifedipine, which is a calcium channel blocker, which can be associated with pretty bad overgrowth of the gingival tissues. Now, usually in these cases, we go back to the patient's referring GP and say, can you change the medication? So you drug substitute, can you change the medication to a non-calcium channel blocker type of medication? And then you do local treatment and sometimes surgery to deal with these types of problems, which can be very severe. This guy, I put on azithromycin at this stage. 7 weeks afterwards, he was already very happy because there's been a lot of shrinkage and healing of the periodontal tissues, even though I hadn't got in there and cleaned him up yet. And after 4 months, you can see how he's almost back to a normal contour of the gingival tissues. Now, I promise you, I did clean him up eventually, and he's been absolutely stable ever since, and he's still taking nifedipine. All right, so bringing this to a close, I've obviously learnt heaps from using this drug. So the main things it's taught me is that something I didn't switch on to before, but periodontal healing actually happens over a long period of time, for years. If you're able to switch off the mechanism whereby the person is susceptible, then you can get healing, but it's not for, you have to be very patient with it. Don't expect things to happen straight away. And I found that it consistently works in people in conjunction with subgingival cleaning and oral hygiene instruction. I'm very hot on oral hygiene. So conventional periodontal treatment is outside in, so it concentrates on plaque and removing the deposits. We delve a little bit into the host modulation with smoking and so forth. Azithromycin probably offers an added benefit than its inside-out treatment. So it's working from the inside and it's having this amazing effect on the periodontal tissues, amazing beneficial effect on the periodontal tissues. I find whenever I talk about azithromycin, that people are also interested in some clinical tips that I can give. One thing that you might find useful is to use these yellow plastic periodontal probes. So get some of these from your local Hugh Freedy rep. They have very flexible tips, and so they slide over the calculus, and they're also very easy to read because of the colour markings. So here's another azithro case of an upper canine that no one could really get anywhere with, pus pouring out of his pocket. A few months later, things had improved significantly. So you can see how readable these probes are, and they, because they're flexible, they don't cause so much pain in the when you're probing. So I would really recommend you all invest in some of those to do your perio probing with. I'm really hot on these interdental brushes. I like the TPs better than the Pixters. I don't bother too much with these little sizes. I'm usually up at this end of the scale, which is sort of industrial strength bottle brushes, and demonstrate this case. So this was actually a GP, a doctor, with an incredibly messy periodontal area here. Radiograph. You're all reaching for your forceps. I can see it all happening now. Anyway, at 3 months he's looking like that, but he needs a lot of help with his cleaning. So this is where he loves it, because that's the only way he can clean in there. They love it. So the bigger the better, as far as I'm concerned. No, I don't think that will ever. He's lost too much bone, and we can't regenerate all that bone. Yeah. It'll settle down, but I'm sure he's not going to lose this 5. I'm pretty sure about it. Okay, so thank you very much for your interest, and I'm really happy to answer some questions. I know there's always lots of questions when I talk about azithro, anyway, I hope you found it to be of interest and stimulate the neurons a bit. So thank you. Yes, there's a question up. Back here, I wouldn't touch that with a barge pole. And I mean, this is really acute. There's pus and inflammation everywhere, and you don't know what's going on. And I would have treated that with an antibiotic anyway. Before I got anywhere near it. So this is more like a periodontal abscess situation, even though it's not a classic perio abscess. So a lot of people ask me that, well, why don't you clean them up first and then give the azithromycin? And that's what a lot of periodontists do. But I've just found my regime is if I think they're severe enough and will warrant, will benefit from a course of azithromycin, is to give it at the initial consult, and then I won't see them for 2 months. And by the time they come back, they've got a completely different periodontal personality. The pockets have all gone down, the tissues have shrunk back, they're not bleeding, they don't have any bleeding anymore. I can see all the calculus, which I can clean off really easily. So that's just the way I've evolved over the last 4 years now. Yeah. And it goes against, periodontal principles, I know, but it works for me, as you can see. Yeah. Well, it does that in people who are susceptible. So it doesn't do it in everyone, but it's for people who are susceptible to arrhythmias. That's why the sudden cardiac death thing comes in. Well, apparently it's in common with other macrolides. Other macrolides are much more liable to do that. Yeah, but if you put, I've got that paper from the New England Journal here. If anyone wants to have a look at it, I'll give you a reference to it. But what the other thing that came out in that paper was that I think 3 people out of 100,000 who took amoxil had sudden cardiac death, and I think it was 8 out of 100,000 who took azithromycin had sudden. So we don't normally associate amoxil as being something we really worry about from that point of view, but clearly this was a population of people. They had all sorts of medical problems. That they were looking at. It wasn't a whole population of the US. Yeah. But yeah, we have to be very careful. I agree. So the question's about peri-implantitis. I don't see a lot of that, but it definitely helps. Yeah, you get the same sort of response. I don't know the answer to that. I don't think anyone studied it. I know there's a study planned in Sydney for peri-implantitis and azithromycin. Yeah. No, I don't think so. No, I think because it does target macrophages as well, and the macrophages are really, as I said, they're the ones that are orchestrating periodontitis. The neutrophils are, they're our first line of defence, but it's the macrophages that also communicating with neutrophils through the cytokines. Yeah, that's right. It delivers it where you want it. Yeah. 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 No. What I said was that it must be still in the stem cells because neutrophils are short-lived. Yeah. So, and no one's done a study on stems, bone marrow cells and azithromycin. Yeah. 1980, yes, yeah, yeah. No, it was. There are a whole lot of different macrolide antibiotics. There's clarithromycin and a whole lot of other ones that have sort of come out of erythromycin. And so these have actually been very effective in controlling chest diseases and different forms of lung disease. In addition to that, people have found that azithromycin is very good for treating trachoma. Probably a single tablet will clear up trachoma. It's used in urinary tract infections, ear infections, sore throats. It's a very widely used antibiotic. Probably not so much in Australia, but certainly in the US. And this periodontal effect is, just completely out of the blue. Yeah.
And the risk of complications is the other effect.
That's the other major one. Yeah, there are some minor ones, but it used to be seen as a really safe antibiotic. Yeah. Right. Yeah. So that macrolides are known to, and the other macrolides are much more worrisome than azithromycin. Yeah. So, are there any questions from the other? If anyone's still there, I'm not sure how we get there, but. Do you guys want to ask any questions?
I'll just ask if there's any questions from Townsville.
I had a question about prescribing azithromycin. Is it something that we can prescribe as general practitioners, or is it something that we have to refer patients to a specialist periodontist before they can get azithromycin?
I'm sorry, we missed the first part of your question. Can you please repeat it?
Is azithromycin a drug that any regular GP dentist can prescribe, or should we be referring these patients to a specialist periodontist to obtain azithromycin for their periodontal treatment?
Thank you. No, you're able to prescribe it. But increasingly, especially after the New England Journal article came out, I'm referring the patient to their GP to clear it with them and to get that extra layer of surety, I suppose. So there's nothing stopping you, a dentist, prescribing it. But as long as you prescribe it as Z-E-D-D, which is what I mentioned earlier in my talk, as if you prescribe it as Zithromax, which is the non-generic form of azithromycin, you're not allowed to prescribe it on the PBS because it's restricted to chest infections, but it's not restricted as the generic form. So I don't know how they work that out. Yeah.
Thank you.
Okay.
All right.
Okay.
No more questions? All right. Look, I'd like to thank Dr. Hirsch for his presentation tonight. I'd also like to thank him for the last 4 weeks that he's spent here at JCU helping our students with their periodontal cases in the clinics. On behalf of JCU, Robert, I'd like to make a small presentation. Thanks very much. Thank you.